Actually, it's not going to be on esophagus. It's actually just flash in general. It's not that currently it's not being used very limited in terms of clinically, but it's somewhat experimental at this point. However, there are clinical trials being planned for various sites, particularly more superficial sites. I'm going to just go over, this is just a quick update. It will be in 10 minutes, hopefully, just quickly going over what's going on with FLASH at this point, and also what's going on at MD Anderson for FLASH. Again, so these are my disclosures. So, of course, the goal of radiotherapy as radiation oncologists is always trying to push the normal tissue complication probability away from the tumor complication or tumor control probability to enhance the therapeutic window. Right, so we know, of course, with physics and engineering, we're constantly improving conformality, of course. That's increased sophistication, increased conformality. But then the goal of that is actually reducing toxicity. But at the same time, we want to actually also improve tumor tissue complication, tumor control probability to enhance this therapeutic window. And that's the goal for radiation oncology, and that's for any patient that we treat. Well, FLASH actually potentially can extend that therapeutic window. So compared to other conventional linear accelerators, which you can compare, even the ProBeam has 10,000 or 10 gray per minute, FLASH is 720,000 centigrade per minute. So in terms of the magnitude of differences of FLASH, it's a high dose or ultra high dose rate of way of delivering treatment. Well, a conventional dose rate compared to FLASH is that's the difference for ultra high dose rate. Well, this type of dose rate actually, of course, changes the biology and interaction with the normal tissue. And so there's been, of course, this is not a new phenomenon. This has actually been studied even actually in the early 70s. They know this type of phenomenon of dose rate and also tumor control probability, and also the ability for normal tissue sparing. However, whatever is old is new again, and this is the first observation. They essentially repeated the same experiment in a preclinical model in this paper that was published in Science Translational Medicine in 2014. And in the study where they actually looked at just 40 gray, about 40 gray per second versus conventional dose rate radiation X-rays. So if you compare 17 gray conventional X-rays versus 70 gray flash, and this is electron flash, in an animal model, we can see here is that where 70 gray conventional dose rate, you see fibrosis in the lung, and you see with flash, you don't see the type of toxicity and scarring effect. And there's other papers that actually show the similar thing. There's actually a huge difference. Of course, normal tissue complication probability is much, much lower when you deliver the dose with high dose rate versus comparing to conventional dose rate. So that was the first paper, and since then there's been hundreds and hundreds of publications now in multiple type of animal models, preclinical models, and of course, majority are in mouse models looking at in GI tract, hematopoiesis, skin, bone, and actually brain. There's a lot of studies in brain in terms of preserving cognitive function within the mice. But then also there's other studies in cats, in dogs, even zebrafish development, as well as in mini pig models, where showing that the ultra high dose rate is able to spare normal tissue. But at the same time, normal tissue complications, but at the same time, a number of publications looking at whether this will also spare tumor control probability. Many studies showing that actually it doesn't. So you still have this, you exhibit the same tumor control, but then also you can have the sparing or normal tissue complications. However, there's a flash modifying factor. It's related to dose. So below 8 gray, there's been many studies now. This is just some of the studies that demonstrated this. The threshold is about 8 to 10 gray. Below that, you don't see the flash effect, but above that dose, you actually see there's a enhancement of you see the flash effect, what they call the flash modifying factor effect. So what is the mechanism that's responsible for the flash effect? Well, there's actually been a number of publications looking at this, and they think it's attributed to both potentially oxygen depletion with high dose rate radiation and the ability to alter or enhance radical recombination. So the generation of free radicals, with flash, you enhance the radical recombination, so reduces the reactive oxygen species that happens within tissue, and that can reduce DNA damage as well as inflammation within tissue. So this is a number of publications showing this, that the oxygen effect is real, in that if you actually try to treat, if you do preclinical models, using atmospheric oxygen level, which is high. This is hyperoxic conditions with 21% atmospheric oxygen. You don't see the flash effect. However, you approach more physiologic oxygen conditions where it approaches about 5%, 1 to 5% is what you normally see oxygen levels within tissue. Then you see the flash effect. And this is demonstrated in multiple models. But then if you actually perfuse the animal, you give back oxygen, or you're using carbogen, or you actually just increase oxygen loading, you can abrogate the flash effect, suggesting that oxygen is an important component of this effect of flash. It's also, there's the publication showing that flash can also alter recombination of reactive oxygen species, so therefore the amount of hydrogen peroxide production is also reduced with flash compared to conventional dose rate. So the putative model and how flash works is actually both of these factors, either oxygen depletion within normal tissue and also enhancing radical recombination can reduce reactive oxygen species production and subsequently decrease DNA damage within tissue, apoptosis, as well as inflammation, therefore results in normal tissue sparing. So we're interested, of course, as a program within MD Anderson, how can we actually translate to patients? Not only we want to understand the biological effect of flash, and of course developing the physics and also establish some flash beamlines and the physics behind the flash, but now how do we translate this to patients? And so there's actually some technologies now. Of course, the proton wave flash is that's being developed through the Varian. I think eventually is now actually through other companies doing this with proton flash. And there's been a clinical trial that was published recently using just palliative dose of radiation, 8 gray, showing that it's feasible to do flash, but then it really, you don't expect any differences, just whether it's feasible to deliver flash. It's called FAST-01. It was published recently. We're using the Mobotron flash, which is the electron flash that can only deliver dose superficially, however, more applicable for cutaneous malignancies. So this is an alliance that we have with a company called Interop. They have this kind of mobile unit to deliver electrons, however, at a high dose rate. So in an alliance, we're not only developing optimization of the device, but also preclinical validation for flash delivery using this device, but also clinical translation. So we have done the preclinical work, which I won't go into, but then we have a clinical trial that's actually being developed and submitted to the FDA for this study called the SURFACE study, which is actually doing flash on cutaneous tumors. And so our trial objectives is really just as a phase 1 study, just showing whether it's feasible to deliver safely. And so there's 2 subgroups of patients. We're going to deliver in this first arm, which is any patients with metastatic disease with cutaneous metastases, where they receive a single fraction and also a 3-fraction dose of flash to see whether it's safe to do so. Subgroup number 2 are patients with a primary disease, melanoma or cutaneous malignancies, where they receive a 5-fraction regimen because that's actually more in line with the standard of care treatment, where the standard of care is 30 gray in 5 fractions, but then we'll do a dose escalation from 30 gray up to 40 gray. But then we don't know whether it's going to be safe or not, so therefore in parallel, we're doing a pig model in these large Yorkshire pig models where we deliver radiation in terms of whether single fraction or fractionated to the pig skin, but then we can do it on both sides. One side, we actually deliver flash dose rate, and on the other opposite side, we do conventional dose rate to really compare the toxicity using the same dose, whether it's single fraction or fractionated. And so we've been doing this. Actually, the data is actually being presented in the upcoming meetings this year. And so the goal is, of course, not only we're going to be able to use this model to study dose per fraction, but also the role for fractionation, any differences between fraction intensity, whether it's once a day or every other day. We'll also be able to study the volume effect, as well as potentially study the tumor response using genetic engineered pig models called KRAS pigs, where we can inject Crelox viruses to actually generate cutaneous tumors and do this type of same effect. Not only can simultaneously look at the normal tissue effect, but also tumor control probability. So this is essentially what's going on at MD Anderson, but also other places around the world. I think this is an emerging technology that we should look out for, and eventually, hopefully, this will benefit our patient and extend this therapeutic window for our radiotherapy treatment. So with that, I just want to, that's it. Thank you so much.
谢谢哈 Dr. Lin. This morning I went to ChatGPT to ask about the flash for esophageal cancer, but the answer is still experimental.
It's still experimental. Actually, it's possible. Because they're doing flash with intraop. So there are people doing intraoperative radiation, and they're using electrons, electron combs. So that's probably a lot more feasible for translation. That's what they're doing now, particularly with this device, where the unit is already used for intraoperative radiation. So they already have that unit, now can deliver flash dose rate. So we do have a clinical trial. Actually, we have this alliance that extends the alliance right now for intraoperative tumors. So after surgery, in high-risk cases, we're going to potentially do flash at the tumor bed. So that's what we plan to do for this first thing. But in the future, if you can have a catheter in the esophagus, yeah, because superficially can apply flash dose, then potentially you can also translate to esophageal cancers. But any surface tumors also as well.
Do you think lung and esophagus, is it a good site for flash treatment?
No, so you can, but so for esophagus, because it's a luminal, it's a tube, right? So you have to reach it through endoscopic means. However, for lung, you can't really do that. Well, bronchoscopically, potentially, right? But I think for lung, what we're talking about is more for externally applied radiation, where you probably need something in depth like protons, where high energy charged particles, or high energy electrons, which is being developed, where you can actually deliver flash deep into tissue. Yeah, right now with electron flash, current energies, you can only do superficial tumors. Yeah.
谢谢，大家还有没有什么问题？问 Professor Lin。假如说没有的话，因为时间的关系，那里赵医师。
Yeah, that's a very good question, actually. So the 1 and 3 and 5. So one fraction is because most of the preclinical studies is done with 1 fraction. And we know if those flash effect is seen with 1 fraction treatment. We're doing 3 fractions because we don't know, maybe normal tissue sparing. No one actually knows the fractionation effect of flash. So we want to study it not only in preclinical models using the pig model, but also in human. Why the 5 fraction is because the standard of, at least at MD Anderson, the standard approach for melanoma and cutaneous malignancies is a 5 fraction regimen of 30 gray in 5 fractions. So that is the standard, and we know using conventional dose rate, there's some toxicity already with that dose rate. It's used, however, clinically. So our cutaneous service, melanoma service, they want to start off with that, and then comparing conventional dose rate and flash and escalate to go to 40 gray. We expect that with conventional dose rate, there's going to be a lot of toxicity, but with flash, the hypothesis that it's going to be better, potentially. Yeah.
Thank you. 我想这个 section 就到这里哈，谢谢大家。Thank you.